Hi, good morning, everyone. Thank you so much for giving me the opportunity to come and talk to you today and share with you some of the findings that are emerging from my PhD research project. And this is a mixed methods investigation of paramedic prescribing in emergency and urgent care. And over the next 20 minutes or so, I just wanted to spend that time talking to you about some of the interesting themes and findings that are coming out of this work. I'm about halfway through my PhD journey now, and as I say, this presentation, rather than being a presentation of a completed package of work, is more of an overview of the research topic, and as I say, some of the interesting themes and findings that are emerging as I kind of progress through collecting and analysing the data from this work. So just by way of a very brief introduction to this research landscape, I know many of you will be quite well versed in this topic, so I didn't want to spend too long on this bit. But independent prescribing was approved for the paramedic profession in 2018 after a significant amount of work by many people here and others to secure that proposal work and convince the Commission on Human Medicines to approve prescribing, which was successful, as I say, in 2018. Since this time, we estimate that somewhere between 1,200 and 1,500 paramedics are now qualified in independent prescribing. And we know that they're using this in a wide range and quite a diverse range of practice settings. And this ranges from primary care to a range of emergency and urgent care settings, which is the focus of my research. And these include emergency departments, ambulance services, a range of urgent care services, and a wide range of secondary care roles and within primary care too. Whilst during the proposal work, a range of benefits were anticipated and proposed to the Commission on Human Medicines to be associated with the introduction of prescribing for paramedics. From an empirical research evidence base, it's currently quite unclear exactly if and how it is contributing to patient care and service delivery. And so we're not really sure how well this is actually being achieved and if there are any important facilitators or barriers that might be influencing this. And this was really the underpinning aim of my doctoral research project, to try and understand and evidence this a bit more comprehensively. So as part of a mixed methods design, a number of different work packages are being undertaken. And as I say, it's really to understand how paramedic prescribing is being used specifically in emergency and urgent care, so emergency departments, ambulance services and a range of urgent care services, to understand the benefits and limitations for patients and services and identify any important facilitators or barriers. The first package of work was to undertake a systematic review, and I'll talk about a few of the, in a focused way, some of the interesting findings from that on the next slide. The second package of work was to speak to and interview a number of subject experts to ascertain their high-level views and insights across the research aims. And then the final package of work will be to undertake some case study research within emergency and urgent care to understand and explore some of the findings and themes that are emerging from this in more detail. So the systematic review was focused on understanding and exploring the use of independent prescribing by all professions in emergency and urgent care settings on an international scale. And this was a bit of a wider focus. It included, as I say, all countries and professions, but also settings such as the urgent treatment by prescribers in community pharmacy, the use of what are called retail health clinics, which are a bit like a pay-for-use urgent care centre in America, and then a range of other settings such as ambulance services and emergency departments, to really understand what the empirical evidence base showed about this, which could be then used to inform my work. So what this showed is, at the moment, from the evidence base, independent prescribers appear to predominantly use their prescriptive work or prescriptive authority to treat lower acuity cases such as minor illness and injury. And this was found even in emergency department roles, where predominantly higher acuity work was left to doctors to prescribe and treat. Potentially, there was, from the limited evidence base around paramedic prescribing, some evidence that paramedics may also be using their prescribing for higher acuity case management as well. But because of the way the data was pooled with other settings such as intensive care, it made it hard to really ascertain exactly how prescribing was being used by paramedics, specifically in emergency and urgent care. And this was felt to be a limitation of that data. However, it did highlight that across the board, prescribing by all professions did show an increase in frequency of treatment, faster access to medicines, and was key to providing care in important settings such as urgent palliative care, and being able to prescribe is felt to be integral to this. It was demonstrated that other professions working particularly in emergency department and out-of-hours palliative care frequently prescribed a very wide range of controlled drugs. And this was useful in highlighting that potentially the concerns that may be experienced by paramedics, as we're currently unable to prescribe these controlled drugs. A range of important organisational factors were also discovered from the systematic review, and these included the ability to use electronic and remote prescribing, having sufficient access to patient records and sufficient access to medical support were also cited by other prescribing professions to be important facilitators. The limited evidence base did highlight how participants in these two studies did describe some potential concerns around the role of ambulance service adoption of paramedic prescribing, and if a clear case of need existed in these settings over a continued use of patient group directions. And this was something I wanted to explore further in the next package of work. Despite the assurances made to the Commission on Human Medicines by the College of Paramedics that paramedic prescribers would adopt prescribing as part of a level 7 master's level advanced practice journey, the review highlighted that both paramedics and other prescribing professions demonstrated quite a wide range of educational backgrounds, from undergraduate to postgraduate level qualifications. However, it wasn't really clear what, if any, impact this had on prescribing practice or patient care. So to explore the research topic more fully, I purposefully sampled a range of subject experts and key stakeholders, and 15 participants agreed to be interviewed. I need to take care around maintaining their anonymity, but they included very senior figures working at strategic director and board level and other senior positions across NHS emergency and urgent care trusts, those working at senior and strategic levels within the College of Paramedics, NHS England, and those working at a regional level to deliver independent prescribing modules through higher education institutes as well. Thematic framework analysis is being used to compare and contrast the different views and insights provided by participants. And as I say, the next few slides are really just a presentation of some of the interesting themes that are emerging as part of this ongoing analysis. So participants talked about or described how independent prescribing has been successfully implemented for paramedics in a range of different emergency and urgent care settings. So within several UK ambulance trusts, it has been adopted by advanced paramedic practitioners in urgent care, and is really focused on providing an enhanced level of urgent care for that lower acuity end of the spectrum, and to provide a more enhanced level of patient care in the community. The ability to undertake remote prescribing was also described by both paramedic prescribers in ambulance services and those working in urgent care services, and this was felt to be a key difference in the role and work of prescribing paramedics in these settings in comparison to those using patient group directions. Paramedics also described using their prescribing in a rotational working through rotational working agreements, particularly between ambulance services and other urgent care services and primary care too. Being able to prescribe was felt to be a key facilitator in both securing these rotational workings, and the placements themselves were also felt to be a key facilitator in enabling prescribing paramedics to grow and learn about new skills and patient presentations outside of their ambulance service roles, which they could then bring back in and enhance their practice in that setting too. Within A&E departments, participants described how prescribing is predominantly adopted by those working as an advanced clinical practitioner in emergency medicine. And this role is associated with a very high level of autonomy as a senior clinician in the emergency department, and a role that requires prescribing for both lower acuity and higher acuity patient presentations. So from the minors area A&E all the way up to resus, being able to use their prescribing skills for that whole range of patient presentations was part of that role. A difference with this setting as well was that prescribing paramedics often, as well as other prescribers, need to delegate the administration of their prescribed medicines to other members of staff. And this was a key difference between urgent care and ambulance service care, where it was more common for the prescribers to issue that treatment directly to the patient. So participants described a range of benefits that they felt have been realised from the introduction of prescribing by paramedics in these settings. And many of these did align with those that were proposed to the Commission on Human Medicines by participants too. So these included enabling paramedics to provide improved access to medicines for patients, deliver an enhanced level of care, deal with more complex cases in the community with an ambulance service role, well, in all roles to be honest, and importantly manage whole episodes of care. And this was felt to be really beneficial across all settings by, for example, in A&E departments, enabling them to work more effectively as part of that multidisciplinary team, relying less on other prescribers to issue the required treatment to their patients. In ambulance services, it enabled them to manage that patient in the entirety of the whole episode of care and not need to refer that patient on to other services, And this enabled the ambulance service in particular to place less burden on the wider health economy. But some participants describe this as the ability to consume their own smoke by managing these patients internally within the ambulance service, rather than assessing them and knowing what they needed, but having to refer them to another service such as primary care or another urgent care service, just to get that medication that they knew that they needed, particularly perhaps when PGDs didn't quite cover that presentation too. Another ability and another benefit within ambulance services was the ability to use the carried stock of PGD medicines in a more enhanced and unrestricted way, but then with the added benefit of them being able to prescribe any other treatments not catered for within this limited formulary, or prescribe ongoing treatment for that same patient once they've dealt with the immediate symptom management. Importantly, the ability to remote prescribe was felt to be important and a key difference between paramedic prescribing and a reliance on PGDs, both within ambulance services and urgent care services too. And being able to prescribe enabled paramedics in some trusts, ambulance trusts, to speak to ambulance crews who are on scene in the community with a patient and then directly and electronically issue that prescription to them, rather than that patient then needing to be seen by a primary care service or another urgent care service. And this all fed into that overall system-wide benefit of being able to manage these patients internally without burdening the wider health economy. So despite this range of anticipated and perceived benefits, participants did describe a range of potential challenges and limitations. Many of these were framed around the unclear case of need for prescribing in ambulance services. And this really started during the work with the Commission on Human Medicines, who themselves had some key concerns around how prescribing was going to work within ambulance services, given that paramedics in these settings did work with a high level of autonomy and in isolation with minimal access to support when needed. And so that was a key concern even in the proposal period. Participants felt that this in some ways still resonates in practice even now, despite it being implemented successfully by several ambulance trusts. Participants felt that more widely there is this potential lack of organisational buy-in framed around this unclear case of need, and so ambulance trusts that are still very much measured on performance times and those key performance metrics. Given that prescribing is difficult to tangibly and quantifiably say it's benefiting the service in these specific ways, added into an unclear case of need over continued use of patient group directions, meant in their opinion that many services had yet decided to adopt prescribing by paramedics and ambulance services for these reasons. And this also is framed around the fact that several participants felt that both in urgent care services and ambulance services, patient group directions actually do enable paramedics to supply and administer the required treatment in up to 60 to 70% of cases. So they do have an important utility that perhaps shouldn't be overlooked, and also then fed into this questionable case of need over then introducing prescribing in these settings. The participants that had adopted prescribing in their ambulance trust also described how their paramedic prescribers still regularly operated within their PGD criteria because of that above point of them catering for quite a significant number of cases. And again, this did feed into the potential, at an organisational level particularly, an unclear case of need as to the role it would play. Some participants felt that whilst there may be unclear benefits for patients in the ambulance service as an organisation, by enabling paramedics to adopt prescribing in this setting may at least contribute to retaining these advanced level staff and giving them an opportunity at continuing their professional development. However, this was tempered by the views of other participants that felt that absolutely prescribing must not be about badge collecting, and it really does need to fill an important gap in practice, and that can be demonstrated when applying to undertake prescribing as well. And the participant that worked at a regional level with delivering independent prescribing education as part of a multidisciplinary module felt that paramedics coming from ambulance backgrounds particularly did struggle to articulate that clear case of need and where there was a gap in their practice that wasn't being fulfilled by PGDs. So there were some really contrasting views between the ambulance trusts that have successfully adopted prescribing and those that potentially described a less clear case of need and perhaps more widely a lack of organisational buy-in by all UK ambulance trusts. And within that too was the discussions around the role of critical care roles, again because many of these drugs are almost exclusively required for immediate administration. Nearly all of them are, or a lot of them are controlled drugs, and critical care paramedics more commonly work as part of a doctor paramedic advanced trauma team, all fed into an even larger concern around an unclear case of need, particularly for the role of critical care paramedics pre-hospitally as well. So participants talked about a number of important facilitators and barriers. Unsurprisingly, controlled drug restrictions is up there as one of the big key ones. So whilst we've had some fantastic progress and news in recent weeks around controlled drug prescribing and the House of Lords, participants did feel that both the current and anticipated future controlled drug restrictions are felt to widely impact on patient care and service delivery across emergency and urgent care. It was felt that by a lot of participants, that they're more keenly felt within emergency department roles and within out-of-hours palliative care. And this is based on, going back to the systematic review findings from other professions, just the sheer fact that a wide formulary of controlled drugs are frequently used in A&E settings. And the ability to prescribe controlled drugs is such a key part of urgent palliative care management. So being able to prescribe for syringe drivers and just-in-case medicines. They were two key areas where being able to prescribe really impacted on patient care, on the autonomy of prescribing paramedics, on their ability to contribute as part of a multidisciplinary team, contribute to service provision in these busy emergency and urgent care environments. And so, for example, even in urgent care services, participants working at a strategic level across those organisations talked about paramedics just weren't sent to a lot of the palliative care work. Even though there was a large volume of calls, it accounts for a significant proportion of cases in this setting, because they couldn't give that controlled drug offering and autonomously manage those patients. They were just left for the doctors to deal with, and that was challenging in services, as we know, with the current landscape, where having those medical prescribers available in large geographical areas as well just added extra challenges. And so it was anticipated that by being able to prescribe controlled drugs will certainly help paramedics to step into that space. The participants felt they were actually very well suited for that work too. Equally within A&E, our experience in high acuity work within the ambulance service, our experience in using controlled drugs were all felt to be important facilitators that would enable us to step into that space and do that very effectively. There was concerns that the limited list of controlled drugs will not enable paramedics to fulfill those advanced autonomous roles in its entirety, and that limited list is going to be insufficient for now. But there was a sense of optimism described by participants, and that this will change in the future. Very much the case needs to now be on demonstrating that clear case of need, generating this evidence to support work going forward to secure unrestricted controlled drug prescribing. A range of organisational factors, which links back to the systematic review findings, were also discussed by participants, and this was around the role of governance and support for prescribing, which is felt to be again more challenging in ambulance services that have had to set this up for the first time, in comparison to settings such as A&E and urgent care services that already had those governance systems in place because other prescribing professions had been working there for some time. And so some participants described there were some existing challenges at the moment in terms of differences between some ambulance service prescribing paramedics having an unrestricted scope and being able to prescribe across a local formulary, to those being restricted by their ambulance trust to a limited formulary, and also not being supported to or allowed to use their prescribing in rotational working posts at the moment as well, due to concerns around governance and litigation around that process. Whilst the Commission on Human Medicines did have some key concerns around whether paramedics and ambulance services would have that sufficient access to medication, to patient information, because of innovations in digital technology, participants actually felt those concerns had now been largely addressed. And so, as a minimum, paramedics in the community have digital access to summary of care records. And those working in emergency department roles in urgent care services often had much more sufficient access, including full primary and secondary care records in some settings and services too. In terms of the role of medical support as well, this was felt to be widely available in settings such as A&E and a real key facilitator to supporting prescribing and helping prescribers develop in that setting. It was widely acknowledged to be almost non-existent sometimes in ambulance services, but there were some contrasting views as to how much that might impact on prescribing practice. So some participants felt it had a real key and clear benefit to supporting prescribing. But other participants, particularly those in ambulance service strategic level positions, felt that actually prescribers operating in that space, given it's associated with a high degree of autonomy, they weren't currently aware that it was having a significant impact on prescribing practice. So a range of contrasting views were described with that aspect too. However, it was widely acknowledged to impact on the ability to upscale the numbers of paramedic prescribers in ambulance services, given it's really hard to secure medical prescriber support for the training period, given they're reliant on areas such as rotational working and GP surgeries, primary care, urgent care services that have their own demands and challenges in trying to support their own staff in developing as prescribers. And so this was felt by some participants to be a real key challenge going forward in generating that critical mass of prescribers within ambulance services as well. Again, feeding into some of these ongoing challenges that are perhaps being experienced in that space. A range of views were also described around the role of master's level education and feeding back into the systematic review findings around this very wide variation. Some participants felt very strongly that independent prescribing by paramedics should absolutely sit as part of a package of advanced clinical practice, should be supported by advanced level 7 education, and this brought with it important critical reasoning skills, a robust and consistent education package, given that we are as a profession still transforming to a fully graduate profession, and in some ways that consistent master's level education helped to offset some of the variation in undergraduate training between paramedics to deliver safe and competent advanced clinicians. This was contrasted with the views of other participants who felt that there was more to being an able prescriber than just your educational background, and so your important things like experience and the setting in which you're prescribing are as important as your educational journey. And obviously, as we know, other professions can adopt prescribing as part of a level 6 package, but those working in higher education roles felt that this was more aligned to those kind of more specialist practice nurse roles, and whereas advanced paramedics are really operating in that advanced space of undifferentiated patient needs and quite a wide prescriptive role, a role very different to their traditional ambulance service roles, that also fed into that case of need for it being as part of a level 7 journey. So in summary, and I know I've run over slightly, potentially there are a range of benefits from the introduction of paramedic prescribing in emergency and urgent care, to enable paramedics to deliver an enhanced level of patient care, contribute more effectively as part of a multidisciplinary team, and enable them to contribute to impacts on the wider health economy less by treating more patients within the services that they're working for. There are key differences between settings. As I say, the role of A&E and urgent care services differs from that of ambulance services, and there are some differences in how prescribing is being used in these settings. There does seem to be some contrasting views around the clear case of need within ambulance services over a continued reliance on PGDs. Both the current and future controlled drug restrictions felt to impact on patient care and service delivery. Potentially more research is needed to really understand the role of education in supporting paramedic prescribing, and this may change in the future as the profession continues to grow and evolve too. And so the next stage of my project will be to understand and explore some of these issues in more detail as I take this forward into the case study research, and that will be starting hopefully in the next few weeks. So thank you for your time. I hope that's been interesting, and if there's time for any questions, I'll be happy to hear those. Thank you.